Good morning or good afternoon now, I guess, everybody. My name is Chris Bruni. I'm the Vice President of Sales for Security Health Plan. I am joined today by Jeff Tucker, who is my co-host for this from the Marshfield Clinic Health System. And our guest today is Dr. Corey Cronrath from Occupational Health. And Jeff will do his formal introduction. I'll just go through a couple of administrative things here, and then we'll get started and hand it off to Jeff. So again, you do have the opportunity to chime in with questions. We do want to hear from you. There's a chat feature in there. Feel free to use that and ask us questions. We'll do our very best to answer them all during this presentation. And if we can't get to them during the presentation, we will make sure we address them and get them out to everybody after. This presentation is being recorded, and it will be available on the Security Health Plan COVID-19 webpage. Click the Employer tab and you'll see all of the presentations. This one should be loaded up by Jen in the next day or two. And of course, if you have pre-registered for this presentation, she will also email it out to you so you have that available to you that way as well. And feel free to go back and look at past presentations. There's some really good information out there. We've been doing this now for quite a few months, and I think there's been a lot of great presentations, and a lot of it is extremely relevant today as it was at the time that it was first presented. So please go back and take a peek. All right, I'm going to hand it off to you, Jeff, and you can continue with the introductions.
Thanks, Chris. As Chris mentioned, I'm Jeff Tucker. I'm VP of Business Development and Care Innovation for the Marshfield Clinic Health System. I'm still experimenting with the best place for camera, so my notes are actually over to the right, so I'm not trying to not make eye contact or anything like that. We have Dr. Corey Cronrath with us. He's the Service Line Medical Director for Occupational Health, and that's now merged with Employee Health. So his job has, I don't even think quadrupling describes it in terms of we're an almost 12,000 employee health system. So we appreciate you making the time to join us today, Dr. Cronrath. He's going to talk about workers' comp. This is another of those backed by popular demand. These topics are driven by you, and this is one that's come up repeatedly. And so Dr. C is here to educate us all and tell us how things are going. We had a leadership meeting this morning, and very sobering statistics on the COVID front, with the numbers up over 200%. And I wrote down a couple of the statistics. We have 145 hospitalized COVID patients right now, which is down slightly. We have 61 in Marshfield alone. I didn't break it out by all of our hospitals. And our lab is working. Overtime is an understatement. This last week, they performed over 13,000 tests. And it wasn't all that long ago that we were going from 8,000 tests, striving to hit the 10,000 mark and maxing things out. And now they've done 13,000. So lots of heroes on the COVID war front, so to speak. So thanks to all that are doing that. I'm going to turn this over to Dr. Cronrath, and welcome, sir.
Thank you. Thanks for having me back. And I know that this was a little bit of a change, so we had to change our topic. I appreciate you asking me. In my military days, we always said semper gumby, always flexible. So that just is the new way of life. So I appreciate it. I'll be talking about workmen's compensation, but really this is going to touch on the big things we've done in Marshfield Clinic Health System in the last 18 months, things I'm excited about, and how we're going to provide a better service to the employers, to you, in the ones we serve. We're here to enrich lives, and it's the workforce and the employers that we want to enrich those lives. Next slide, please. So being the Director of Occupational and Employee Health really helps me out understanding, one, the clinical side. That's the occupational health side. That's where I'm making a lot of the causation determinations or performing the occupational health actual procedures, looking those patients in the eyes. But I'm the employee health director as well. And with those patients, I can't see them in the clinical at all. And I'm working on the employer side. So running into the same challenges that a lot of you run into. And it really helps give me a full understanding of the big picture instead of the smaller straw view of the clinical picture. So there's two pictures here on the screen here. The one on the left I put up for a very good reason. I lived a double life. I was in the Army for many years before I came to Marshfield Clinic Health System, and that's Jimmy, the pilot there that I'm looking in his ear. We were flying from Roswell, New Mexico, had to land in Las Cruces for a splash of gas, and then we were on our way over to Tucson, Arizona. Well, flight surgeons have to ride in the back of the aircraft, basically an on-site care. And when we got out, Jimmy said, "I can't hear anything. I don't know what happened. It was good when I got in. I can't hear a thing now." Being on the aircraft, I'm a little concerned because we're either not going to complete our mission, or worse, he's going to fly not being able to hear and miss a radio call and then jeopardize many lives. And so as he hopped out, I said, I got my bag, I got my otoscope, let me take a quick look in your ear. I look in his ear and I see what looks like a hemotympanum or a ruptured eardrum. And then I look a little closer and I notice that no, the edges are too well defined. Well, his earbud, his communication piece, the earbud from it fell off into his ear, pulled some tweezers and just pulled that out, and he could hear fine. And it shows the moral of this story is on-site services do very small things that look inconsequential, but really they have huge impacts for mission accomplishment. And so we were able to finish our mission and do it safely just by having someone with the ability to look in an ear and pull an earbud out. Well, that was my last life, which I loved very much. My wife, though, decided that she was tired of raising our children alone, and after multiple deployments, told me I had to quit playing on helicopters and get a real job. And hence, I'm here at Marshfield in the nice suit, living a completely different type of civilian life. And so that's me in a nutshell. Next slide. And I came to Marshfield because I love the mission of enriching lives. In occupational health, the lives we enrich are the workforce of Wisconsin, and that includes the employers. And when we go into our values, patient-centered is on the top of the list. For me, that means it's the most important. Talk to others, they all have equal value. But what I really like about patient-centered is in occupational health, we have 3 patients. It's not just the person that we're looking in the eyes to in the clinical exam room. It's also the employee to the left and right that relies on them for safe working, and it's the employer who brings together the group to meet a common goal that pushes our societies forward. So that's how I look at our values in patient-centered, and that's what I teach to our team members. Next slide. So there's 3 things I really want to talk about what we're doing over here at MCHS and occupational medicine specific. It's what we've done with workman's compensation, the industrial athlete program, and COVID response. So just going to touch on those 3 today with our shorter time period. There's many other things we're doing, but these are the top I want to brush on today. Next slide. So the workman's compensation, a lot of it, and many of you know this anyways, the background that we're working in, we're working where the injured worker gets to choose the provider. And if they want a second opinion, they get a second opinion. So they can pick and choose who they're going to see. The first 3 days off are uncompensated. This point is very important for us when we're talking to some of our urgent care emergency department physicians, letting them know how they negatively impact their patient population when they take people off work completely. Also, that in Wisconsin, only a physician can make a causation determination, and this is also very, very important so that we're not causing undue administrative burdens for employers, for injured workers, or for the healthcare providers themselves. And causation must be determined to a reasonable degree of medical probability. This last point creates the most debate. It creates debate within occupational medicine board certified physicians. It creates debates within MCHS, Aspirus, Ascension, HSHS. You take your pick. Providers within those organizations will disagree on what this means, And then in between organizations, we disagree on what this means. Next slide. And this is the guidance that's actually given out by workforce development to providers making causation determinations in the state, and you only have to be licensed as a provider. Doesn't matter what that specialty is. I'm going to read part of this verbatim to you. I think it's that important. And it's the question on the WKC 16B concerning causation and disability are to be answered to a reasonable degree of medical probability. The Workers' Compensation Act does not require 100% certainty. The standard is a reasonable degree of medical probability, meaning more likely than not, as opposed to speculation on a mere possibility. So this is where the debate comes over and over and over again. And what does that mean? So in science, for a reasonable degree of medical certainty or probability, that's 95%. We use statistics and we use an alpha, false negative, of 5%. So that's a very high bar, and that's obviously not what they're talking about here. But what is that bar then? Is it just we're 50% sure that the injury is leading to the disability and that the injury was caused by work or happened at work? What does possible versus probable mean? What is aggravation versus exacerbation? What is manifestation? And these are the discussions that go round and round and round. And that's why as an employer, there's so much frustration because the variability of what you're getting back on injuries is very wide depending on the provider that the employee chose to see. And in the state of Wisconsin, you're unable to direct them to one specific provider. So your variability is going to be very wide. You'll see the same injury, same mechanism of injury and patterns in very different opinions on whether it was work related or not. So I want to go into what I teach. Next slide, please. I feel that as providers, we're scientists and we need to follow the scientific method in making our determinations on workplace relatedness or being caused by work. So I follow the American Medical Association's guide. It's the book there on the table. And this is the 6 steps of causation, which was agreed upon by the American College of Occupational Environmental Medicine, ACOEM, and the National Institute of Occupational Safety and Health. It was a collaborative agreement. And so there's 6 steps that I go through and that I teach others to go through. Whether they follow it, it's up to them because they are licensed in the state of Wisconsin. So they don't have to follow this ruling. They have to just be, more likely than not, based whatever that definition is for them. But I teach, number 1, you need to identify the evidence. Is there actually an injury there? So if it's a low back pain, what does the x-ray say? What does the MRI say? What findings are there? What is the range of motion? What is the actual strength? And to pull the pain piece out of it, what can they do? And then later on, maybe bring in pain, but pain is a symptom and isn't actual evidence of injury. It's not objective. The next is review and assess the available epidemiological literature out there. So the mechanism of injury, does it line up with actually causing the injury at hand? Are we talking about let's use a tear of a tendon, and we'll use an ACL tear. Is the mechanism of injury for an ACL tear was enough force pounds created to cause that tear, and does the literature support that or not? And that's why we have to go back to the medical literature for these things. So what does the epidemiological evidence say? One caveat with this is we have a lot of epidemiological research for age, smoking, obesity, diabetes, and other type of medical conditions, just because of the funding to go into and look at these things. For work relatedness, the funding is not there, so it is much more sparse and a little more difficult to find the epidemiological data. It's really easy for exposures, if we're talking heavy metals, cadmium, chromium, etc., but it's more difficult on those musculoskeletal injuries. It does exist, though, to a certain degree. The next is consider other relevant factors. I have knee pain. Well, do you have knee pain from the job you were doing and it's osteoarthritis? Let's use that as the actual diagnosis. Is it from the job itself, or is it from the sports that you played as a child, the arthroscopic surgeries you had in college after your football playing years, and then the obesity you had for the last 20 years? Or is it actually from the job that you were doing? And you need to parse those things out, and that's where possible versus probable comes into play. It's possible work caused it, but not probable, or vice versa, based off of the actual evidence. Also, with the evidence is the job description. What is the person doing? What are the exposures? The next step, 5, is judge the validity of testimony. Is this an individual where you believe the story you're being told, or are there a bunch of holes? The injury occurred on multiple different days in the medical record, or the accident report doesn't line up with the reported date of injury, and looking at the whole picture, and then form your conclusion. So that's what we teach at Marshfield for causation. When I talk to most physicians about that, they go, that's too much, I'm sending it to you. Next slide. So internally, what have we done in Marshfield to make a better product and service for you? The first thing is our backbone are these regional occupational health nurse managers / liaisons. So each region, we've divided into 6 regions, has an RN that is responsible for making sure that the services rendered and then the information that needs to go back to the employer occurs. They're the liaison between the employer and the medical system. Whether it's I didn't get a return to work, or this return to work doesn't make sense, this person was put off work for 3 weeks and we have sedentary work for them to do, those kinds of questions. The nurses, these liaisons, collect that information and feed it back to us. They correct it on their own by directly working with the providers, or they come to myself or someone else in occupational health to correct these issues and then identify where we need to go and do training. We've focused our training on the occupational health basics to the urgent cares and emergency departments. So we've been going through and providing the occupational health basic course to these providers. And for that course, there's really 4 takeaways that are hammered home for these providers. If someone's coming in, first aid first, if possible, if it's medically relevant, and then explaining to that provider the importance of steri strips, which are first aid, not an OSHA 300A, versus putting in sutures if they're not necessary, and what that means, and how OSHA uses OSHA 300As to identify unsafe workplaces for coming in and doing inspections. And if these are just some accidents, don't actually require the additional treatment, we do not want to use OSHA services to inspect safe workplaces versus unsafe ones. And so going down that road and teaching them to do first aid first. Second is take the body part off work, not the person. As the provider, you don't really know the workplaces very well. Many employers have return to work programs, sedentary positions, light duty positions, and we need to get these employees back to work. And the reason it matters medically is because the morbidity is much lower. They heal so much better and heal more fully when people stay in the workforce versus taking them off and putting them at the house. There's many reasons to this that we go into to convince our providers that this is actually true, and the medical literature is solid on that point. We teach them about causation and why it needs to be a physician and not an advanced practice provider, and all the administrative burdens and negative impacts to employees, employers, and to themselves and the healthcare system. And the last one we focus on is drug testing. Make sure you drug test accidents at the time of the visit and not 16 hours later, because we're going to lose the evidence that we need. It makes the test less usable. Next slide. So the industrial athlete program has been reinvigorated. We've brought athletic trainers onto the occupational health team. We have 3 of them. This one really, really excites me, actually. There's a full program, but the baseball card program is a facet of the entire program that I'm going to get into. What we're using as the foundation for this is the Work Well model. It's a national model, and we chose Work Well just because of how many tools it has available. And this also helps us standardize the program over the entire system when you're using a nationally recognized model. The baseball card program is really a pre-placement program, and this one really excites me. I typically get frustrated when I'm doing pre-placement exams if I don't feel that the exam is value added to the employer, because what's the point if it's not? And so for this baseball card program, it's going to be highly effective for those that are doing moderate and heavy level work, manufacturing industries, some other industries as well. And it's pre-placement. We send an athletic trainer or physical therapist to the job sites to analyze each job being performed, whether you're rotating them through 5 different jobs, daily, weekly, whatever it might be, or having one position. We're getting objective data of what strength is needed, how many foot-pounds per square inch, what's the range of motion, do we need flexion at the shoulder to 90 degrees and then another 60 degrees of adduction, and going through those different movements. Then for the pre-placement at our Loyal Center and in our Marshfield Center, we have what's called a BTE machine. This BTE is a company, BTE Technologies. These are very expensive pieces of machinery, but what they can do is basically isometric strength. So how much can someone lift with their arms in flexion with the biceps and ancillary muscles? What is that strength? Compare that strength to the job that they're doing. If this strength meets perfectly with it, they can, let's say, deadlift 50 pounds, and 50 pounds is all they can deadlift, then that's not a good fit for the person. So when we send the pre-placement back, we can have that data coming back, and you as the employer, knowing that they have to do this job over and over again for multiple weeks, can decide to put in a work hardening program or decide they don't meet the essential functions of the job. And we can do that with many different things. It doesn't just have to be lower extremity strength, upper extremity, et cetera, et cetera. And so the product coming back to the employer was hopefully a picture of the employee with the job positions, and then on the back are your statistics the stats you're looking for to see what jobs they would fit in with a lower risk of injury. It also includes on-site MSK prevention evaluation with athletic trainers fit that best, basically doing a lot of what you would see with your athletes, Theragun or Ready Set, which is ice under compression, and just giving that extra Cadillac service to your employees. Spoke of the work hardening program a little bit for returning someone to work or getting someone to where they need to be in order to perform the positions. Education, live presentations work best, and on-the-spot education is really the most effective. Next slide. COVID response. I'm going to go over this very quickly because I want to make sure we get time for questions. And I'm sure you've heard this over and over again. We are still doing the no-charge occupational health RN evaluations of workplace for risk mitigation techniques. Our seal of approval, which comes with a sticker that you can put on your front window. We go through and first see what risk are you for virus transmission, then what risk mitigation strategies need to be put in place to prevent that risk. The COVID response emails are still up and running. They're manned by either occupational health specific nurse practitioners, nurses. If they can't answer it, it comes to me. They do return to work. They do COVID-19 testing. If you just have a question, feel free to send that in. And we are maintaining all our on-site and in-clinic services. Adding new services are case-by-case basis, depending on our staffing at the time. Next slide. And that completes the presentation, but I just did want to show you the seal of approval. what we do give for the window clings. Are there any questions?
Great. I do have a question, Corey. This is something that Jeff and I have been encountering. So for those of you that are listening in on this presentation, watching today, we are working with... What's that?
Well, your mic is, now mine is muted. Can you hear me?
I can hear you just fine. You can hear me?
Okay. Now I can hear you better. Yep, go ahead.
All right. Thank you. So Jeff and I have been participating in a couple of different employer advisory groups around the state. And we would be very interested in having others join those groups. So if you are interested, please reach out to Jeff or to myself, and we will work with you to get on these advisory panels. But question that comes up from that, Corey, related to occupational medicine pretty consistently is, how do we go about building that relationship? Because we can't steer our employees, like you said in your presentation, to a particular provider. There's not a network that you can just log into and use. Yet we do know that employers do have relationships or will often see their employees going to the same docs for occupation-related, workers' comp-related injuries. What would be your suggestion to build that relationship? So as you had mentioned, a lot of providers don't know that workplace, so that you can have a better approach to that worker's injury and how you want to approach it going forward.
Yeah, I would say one term we commonly use, grease the skids. So if you, depending on your location, and you like the services of Marshfield or whatever the organization is, greasing the skids could be as simple as, I have a workplace injury, we will pay for your taxi ride to the urgent care or emergency department of choice. I really hope that's Marshfield, because I've been talking to these providers and they're the best in the state. They're taking the teachings to heart and grease the skids, so that now you have your taxi ride right to that organization and back. You can make recommendations, but you just can't direct. You can, and so that's what I would say. You got to get a little bit creative, but wherever your employees are going, sometimes it works to reach out and talk to those departments as well, to develop that safety manager relationship with the providers. So for myself, I have relationships with many safety managers across the state, and as you can see, my cell phone number is there on the screen. So if you have questions, you can call me directly. I'll answer. You might have to leave a message, but I'll answer. And it doesn't matter if the employee went to what organization they went to. I'll give you the knowledge I have.
Excellent. I see we're down to 2 minutes. So my longer questions I'm going to not go with, and you answered one of my questions for you, which is the education of providers about restrictions and restrictions on body parts versus taking the employee completely off work. That was feedback that I know we've heard in the past, and it sounds like you've been working actively to educate providers throughout the system. I had a general question for you, and it's actually, before I ask the question, do we have any other questions that have come in? I'm not seeing anything right now. My general question for you is related to COVID, and COVID's been hitting our own workforce hard, and as well as those that are still actively working and have their plants running and all that sort of thing. Is COVID, at a global level, how is COVID affecting the workforce? Are we seeing the acuity of injuries and that sort of thing increase, or is it more they're catching the virus and they're down because of the virus, that sort of thing?
Yeah, so from the numbers I've seen, it's been a little bit of a mixed bag depending what survey or which study you look at. The BLS, Bureau of Labor Statistics, I haven't seen large increases yet on those numbers, but they're a little more difficult to parse out. There's two theories that are coming down One of them is you're going to see increased injuries because we're asking employees to do more. They're stressed higher, job satisfaction's going down, and we know that those psychosocial factors are directly correlate with injuries. The other side of the house in the conversations and debate is that you're seeing less injuries because people are more afraid about not being able to keep their positions, and therefore they're sweeping them under the rug and not reporting them. It's big overall. I'm personally not seeing an increase in injuries though.
Okay, thank you.
All right, we are kind of up against the clock. So since we have no other questions from the audience, I think we will end our presentation today. The phone number for our business health solutions sales team. Please reach out to them if you have questions or want to talk to our occupational medicine staff about anything, even if it is just getting the sticker for your window, because again, having that seal of approval does give peace of mind to those employees, and so we do encourage you to use that and take advantage of that free service. Corey, thank you again. A great presentation. Corey is a repeat visitor to our Wednesday webinar series. I think this is your third or fourth time. I'm not sure which. Third or fourth time as a presenter here. So we have really enjoyed having him on and talking about topics as they relate to all the different things that can happen in the workplace. And of course, this has been a very interesting year for all of that. But thanks again. And again, we will put this presentation out. Jen will have it out to everybody within about 24 hours. If you do have other questions or want to hear more about other topics, please respond to the survey that we'll send out as well. We want to hear from you, and we definitely want to make this all about the topics that you want to hear more about. So again, Jeff, Corey, thanks so much for your time today, and be well, everybody.
Absolutely. Thanks, everyone.